Hello class, welcome to this class. Today we are going to look at the pathograph. The pathograph is also known as the pathogram. It is a legal document that we use to monitor labor. The pathograph is divided into three components. These three components enable us to monitor the fetal heart rate, that is the status of the fetus. It helps us also to monitor the progress of labor and also to monitor the maternal condition. When we look at the pathograph, yes, when we look at the pathograph, it has the upper component. This is the upper component where we have the name of the client, the gravidity of the client, the parity of the client, the hospital number of the client, the date of admission of the client, time of admission, and the status of the membranes. The name is significant in that it helps us to identify our client by name. Gravidity is also very important because it tells us how many times this client has been pregnant or gravid. Parity tells us how many times has this client delivered. Is it once? Is it twice? Then the hospital number is extremely important because this is the unique identification number of the client. This number has no other client, so it is not possible to confuse a client if you have a unique identification number for that client. On the side of the membranes, if the membranes are ruptured, then we put a tick on the pathograph. If they are not ruptured, then we just put not ruptured. Now we come to the most important component of the pathograph, and this is the first part where we monitor the fetal condition. It is very, very important because it is the reason why this mother was pregnant for 40 weeks, and without a healthy fetus, then it means the 40 weeks are actually wasted. We look at the y-axis, which denotes the fetal heart rate or the fetal heartbeat, and the x-axis, which comprises of the number of hours that this mother is in labor. This is called the ordinate, and this is the abscissa. On the y-axis, we find two lines which are in bold. One at 120, running horizontally, and another one at 160. The line that is 120 shows that for a normal fetal heart rate or heartbeat, it is supposed to be 120 for the fetus. When the baby is still in the uterus, we call it the fetus. Once it is born, then we call it the baby. Then the upper limit is supposed to be 160 beats per minute. This fetal heart rate is monitored using the fetoscope. In case the fetal heart rate goes below 120 beats per minute, it means we are having what we call fetal bradycardia. If it goes above 160 beats per minute, it means we are having what we call fetal tachycardia. This is very significant to us as midwives because fetal bradycardia or fetal tachycardia means that the fetus is in distress, so we are doing well. So we need to take action immediately. What are some of the causes of fetal tachycardia and fetal bradycardia? When the fetus is in distress, first the heartbeat will be very high, 160 beats per minute and above. Then if the distress is not handled, the fetal heart rate will now become irregular. After the fetal heartbeat is irregular, it will progress to fetal bradycardia, below 120 or below 120 beats per minute. This is an obstetric emergency, and we have to take the mother either for cesarean section, unless this mother was almost delivering. It is an obstetric emergency. As midwives, we have to act very, very fast. In case the fetal heart rate is just below the normal, approaching 120, we can actually correct it before it goes to 120 by giving the mother a drip of normal saline. So the next very important component of the pathograph is the one that monitors the cervical dilatation and the descent of the fetus. It is again a very important component of the pathograph because it tells us how the cervix is dilating. For the baby to be born, the cervix must dilate, and it dilates from 0 centimeters to 10 centimeters. So on the y-axis, we have the cervical dilatation, which is 0 to 10. On the x-axis, we have the number of hours, 0 to 24. Of course, it's not normal for us midwives to allow a mother to labor for a whole 24 hours. So in case labor is prolonged, there are certain interventions that we do, which is called augmentation of labor. So we have the latent phase and the active phase. Now, when a mother comes in labor, or a client, and is in the latent phase, we expect for the first-time mothers, whom we call the prime gravida, to progress slowly. But for the mothers who have delivered before, whom we call the multigravida, they progress rather faster than the prime gravida. So what does our graph here mean? This means that when a mother comes, cervical dilatation is at 3 centimeters, and she stays for around 8 hours. We are on the alert line, and we have to take action. If she comes, and then at around 4 hours, the cervical dilatation is 4 centimeters, we are in the active phase, and we are also not worried about this mother. What does the action line mean? The action line means that if a mother comes at around 3 centimeters and then 12 hours down the line or 11 hours down the line, cervical dilatation is 4 centimeters. 11 hours, 4 centimeters. We have to take action. We do what we call augmentation of labor. There are methods for augmenting labor. Some are pharmacological, others are mechanical. Pharmacological methods of augmenting labor or hastening labor or speeding up labor, we normally use a drug we call oxytocin or pitocin, and we put it in a drip of normal saline, and we titrate the drip every 30 minutes. And we can also do artificial rupture of membranes, again to augment the labor, in case membranes were not ruptured when this client came. So this is for the cervical dilatation. It is measured using 2 fingers which are very significant for us as midwives. For the small fetus, the cervix does not have to go to 10 centimeters. This is just an arbitrary figure to guide us as midwives. But for the big babies, sometimes you find the cervical dilatation. You may not be able to get it using your 2 fingers, and you actually must go around the cervix to feel whether there is a rim of the cervix or the cervix is fully dilated. Then it is plotted using an X, and we use blue color when plotting this part of the patograph. But for the fetal heart rate, which we looked at earlier, that one, the official color, internationally accepted color, is green. So midwives, we always carry with us 3 colors of pen: black, green, blue, and red. Red is for, of course, where we sense danger. Then we have a line here that we are calling the descent of the fetal head or descent of the fetal cephalic. Descent is measured using the degree of engagement into the pelvic brim, and we normally palpate the part that is above the pelvic brim. Why don't we want to rely on the part that has gone into the pelvic brim? This is because the part that has gone into the pelvic brim might not be necessarily the head that is descending. It could actually be the caput succedaneum that we are feeling on vaginal examination. This is why the part that is not gone into the inlet is the most reliable. So when one part of the head has gone in, we say that the head is 4/5 up. When not part has gone in, it is 5/5 up. When one part has gone into the inlet, then the head is 4/5 up. When 2 parts have gone in, we say that the head or the cephalic is 3/5 up, and so on, until when 4 parts of the head have gone into the pelvic inlet, we say that the head is now 4/5 up. When the whole head has gone into the pelvic inlet, we can no longer palpate the head using the Leopold's maneuver, and everything is into the pelvic inlet or in the pelvis. We know that a normal delivery is now imminent. It may take place, most probably, because the whole of the head has gone in. But when delivery has taken place, that is the time we can say that the head is at station 0. Before delivery, the head is never at station 0 because it's not yet delivered. Now, these two are interrelated, the cervical dilatation and the descent, because the more suitable the cervix, the better are the prospects for a descent. And for a descent to take place properly, the head also must be of the same vertex presentation, whereby for a vertex presentation to take place, the presenting diameters must be the biparietal diameters, which are 9.5 centimeters, and the suboccipital bregmatic diameter, which is also 9.5. This is the most favorable cephalic presentation. Of course, as we learned earlier in other classes, there are other cephalic presentations: the brow, which is the most unfavorable; the face presentation, not favorable at all; the occipital posterior positions, also not favorable. There are also parameters of the cervix that we look at that enable us to decide, is this cervix favorable for a normal delivery? We score that cervix using the Bishop's score. It has 5 parameters. The first one is the degree of cervical effacement. Cervical effacement. What is cervical effacement? This is the taking up of the cervix into the lower uterine segment. If a cervix has had effacement, then delivery will be more imminent. The other parameter we look at the cervix is the degree of softening of the cervix. A sign we call the Osiander sign. The softer the cervix, the more favorable the cervix is for delivery. The other thing we look at the cervix, as we score it, is the position of the cervix. We have three positions of the cervix. We have an anterior cervix, we have a posterior cervix, we can also have a central cervix. The cervix that is more suited for delivery is the anterior cervix, and the more anterior the cervix, the more imminent the delivery. Of course, we also look at the length of the cervix. The longer the cervix, the less the expectations for a normal delivery, but the shorter the cervix, the better for us as midwives. And then the degree of dilatation of the cervix when the mother comes into labor. The faster the cervix is dilated, the better the prospects for a normal delivery. And the slower it is dilating, the worse the prospects. That is the component of the cervix and the descent of the cephalic. The next component is where, as midwives, as we can see there, we measure the contractions. Contractions of the uterus are measured using palpation, using the palm of the hand, and the palpation is done on the mother's abdomen. The contractions are usually charted using a black pen. Now, the contractions can either be mild, moderate, or severe. For mild contractions, these contractions take less than 20 seconds every 10 minutes. Contractions are measured every 10 minutes. For moderate contractions, these are contractions that are between 20 to 40 seconds, and they are measured again every 10 minutes. It may be one contraction every 10 minutes. They may be 2 contractions, 3 contractions, 4 contractions, 5 contractions, as indicated here, 1, 2, 3, 4, 5. But they are done every 10 minutes. When a mother is about to deliver, the contractions become more severe, lasting over 40 seconds, and they also become more frequent. They may be 3 to 4. 5 is not very common. Again, when a mother is in the latent stage of labor, the contractions are mild and they are usually fewer. In case the contrary happens, maybe the mother is in latent stage, has just come in labor, and the contractions are 4, lasting maybe over 40 seconds. It means we are having precipitate labor, and we need to slow the rate of that labor using drugs that we call tocolytics, because when the contractions are very severe and it's early labor, it means the baby is going to be in danger of fetal distress because of very rapid descent, and also the mother is in danger because she may suffer a ruptured uterus because of those severe contractions. On the other hand, if the mother is in advanced labor, stages of active labor, and the contractions all of a sudden cease to be severe or moderate, they go to mild. Again, this calls for augmentation of labor using the drugs that we said and using artificial rupture of membranes. So oxytocin is the drug that we use to augment or to speed up labor, and it is measured in drops per minute. We start with 10 drops per minute and we escalate by 5 drops every 30 minutes until after around 6 hours we are supposed to be through with escalating the drops per minute from 10 to 60 drops per minute, with the hope that even before we get to 60 drops per minute, that mother will already have delivered. That is for the oxytocin or pitocin, and it is charted here. How many units? 5 international units, and the drops per minute. For these contractions, when the contractions are mild, we use dots. When the contractions are moderate, then we draw lines. When the contractions are severe, then that time we actually shade with our black pen. Then next is the drugs given during labor. Sometimes a mother will come to us, she is diabetic, she is a hypertensive, she has all these medical problems. So any drug that is given during labor has to be indicated along this part of the patograph. This is because it is important to know what drugs we gave to this mother during labor, because they may affect labor either directly or indirectly. It is also a mode of documentation for us as midwives, because as we said, this is a legal document that is internationally accepted, developed by World Health Organization, and used by all midwives all over the world. Then the next part of the patograph is where we monitor the maternal condition. Contractions, we are measuring the progress of labor. Now, here's where we are monitoring the maternal condition. For the fetal heart rate, we are monitoring the fetal condition. So, again on the y-axis, we see the pulse rate, number of beats per minute, and on the x-axis, this is the hours. They may go up to 24, but as I said earlier, as midwives, it is unlikely that we are going to allow a mother to labor for 24 hours because we usually have to intervene. So the pulse rate for the adult is different from the one for the fetus. As you can see, the one for the adult, 60 beats per minute is absolutely normal, depending on the age of the mother. Then it goes up to around 84 per minute, beats per minute. Any heart rate in a mother that is above 82 beats per minute will arouse interest to us as midwives, because it means this mother could be going into maternal distress, in which case we have to take corrective action. But for the fetus, it was between 120 and 160 beats per minute. These measurements, they go up to 180. 180 is not for a pulse rate, because no mother will be alive with a pulse rate of 180 beats per minute. So this is for the blood pressure. As you can see, the blood pressure and the pulse. BP denotes blood pressure. Pulse denotes the heartbeat. So blood pressure, it is measured using a sphygmomanometer, and normal blood pressure is 110 over 170 millimeters of mercury. It may go to 120, of which now as midwives we must be extremely careful when it goes to 120. Over 80, all this is normal. Any blood pressure above 120 is not normal for midwives. This is because already during pregnancy there was the hemodilution of pregnancy, and the blood pressure was slightly lower because of that hemodilution. So anything above 120 will raise eyebrows for us as midwives. So the pulse is charted using a dot, and the blood pressure is charted using a line like this. If the blood pressure is 140 over 80, I put a line here and I chart between the boxes. But the pulse rate is charted at the junction of the boxes. Let us look at the next component of the pathograph. And this is the one that looks at the temperature of the mother. Again, the temperature of the mother is very, very important. Normal temperature is from 36.4 degrees Celsius or 36.3 degrees Celsius up to 37.2 degrees Celsius. A temperature that goes beyond that, 36, is known, a temperature that goes beyond 37.2 degrees Celsius is known as pyrexia. A temperature that is below 35.5 degrees Celsius is known as subnormal. Why would the temperature of a mother who came when she's absolutely normal go up or go down? The most common occurrence is when it goes up. Why would it go up? In case of maternal distress, the pulse rate is going to be high and the temperature too is going to rise. So we have to take corrective action as midwives. Then the last component down here, which is showing protein. This is urinalysis. When a mother is in labor, we keep on checking the urinary output, the quantity, and the constituents of that urine. This is because sometimes a mother will come with us, to us when she has eclampsia or pre-eclampsia and may suffer diminished urinary output. This is where the quantity now comes in. Little urine is known as oliguria. Too much urine is known as polyuria. So we measure the quantity. Then we also check for the other component, the protein component. In case there is protein in urine, it means that we have a malfunction in the kidneys, but we need to be careful about the protein because this protein could come from whatever is draining per vagina, because it could be just blood or simply show. The other component of urine that as midwives we need to be careful about is the glucose. Is there any glucose in urine? Because glucose in urine is completely abnormal. It shows there is gestational diabetes, which needs to be attended to as a matter of urgency, and this becomes an obstetric emergency. The other component is we measure the ketones. In case the ketones are plus or +2, +3, it means the mother is not well nourished. She could go into maternal distress. So again, we have to correct this maternal distress. Then the last component is the total blood loss once the mother has delivered. What is our total blood loss in a normal delivery? It is 500 mLs. 500 mLs is normal blood loss, but in case it is less than 500 milliliters and it affects the mother, then it is still considered abnormal blood loss if the mother is affected. But in cesarean section, we usually allow up to 100 milliliters of blood loss. Any amount above 1,000 milliliters in cesarean section, we call it postpartum hemorrhage. Any amount more than 500 milliliters of blood loss in a normal delivery, we call it postpartum hemorrhage. So we talked about the components of the pathograph, and we say that they are 3, and the pathograph is usually used by midwives, a legal document used to measure the progress of labor, measures the progress of the fetus, of the labor, and the maternal condition. So it is a very important document for us as midwives, and we are expected to use it. It is also a mode of documentation for us as midwives, and it helps us to pass information from one midwife to another. It also can be used for research purposes. Nurses or midwives are researchers, and when we want to know how many mothers had normal labor, we are able to tell. Within this period, this number of mothers had normal labor. How many mothers had abnormal labor within this period of time that we are doing research? Again, we can do a records review, and we are able to tell this number of mothers had abnormal labor. This pathograph is also going to tell us whether the baby came out alive. So in case one wants to do research, you do a records review, and you can tell from the pathograph, was the baby eventually alive or not? What was the APGAR score of that baby? What was the gender? And what was the birth weight of that baby? Thank you.
These televised lectures supplement our robust online learning going on our MKU online platform. You can view more on our televised lectures via our online platform. We are in a digital era, and Mount Kenya University knows this. The following are the steps to follow so as to complete your online application. Download the application form from the website www.mku.ac.ke. Attach copies of your academic certificates and ID. Pay the application fees via M-Pesa pay bill number 270988. Your ID is the account number. 2,000 shillings is the charge for a postgraduate. You can also deposit in the bank accounts provided on the website. Then email all the above to apply@mku.ac.ke.